Yes. And now, the last but not the least, I will introduce my favorite fellow, Dr. Samara, who is who after its fellowship in Onassis Cardiac Surgery Center now is assistant professor in the University of Ioannina, and she is responsible for cardiac anesthesia in the hospital. Dr. Samara, please start your presentation.
Thank you, Dr. Adoniou. After this EACTAIC Fellowship, the truth is that my life has taken a whole other part, a whole other turn. And so we will continue with another case report with a patient with pulmonary hypertension undergoing a non-cardiac surgery in a non-expert center, something that might happen to almost every anesthesiologist. We were saying that people with patients with pulmonary hypertension now live longer thanks to their new drugs and better care. So more and more patients present to the OR for non-cardiac surgery for the rest of their comorbidities. A US code study has demonstrated a threefold increase in over a decade in pulmonary hypertension patients undergoing non-cardiac surgery. Whereas pulmonary hypertension is an independent factor for a risk of morbidity and mortality, even when they are handled in expert centers. More specifically, the likelihood of an adverse outcome is 2.4 times higher. Okay, mortality is even higher when those patients are undergoing emergency surgery, whereas complications are consistently higher in every kind of non-cardiac surgery. Most of their complications occur during the OR and within 48 hours after, with the major contributors to be acute respiratory failure and RV failure. The problem is that the literature on this subject is limited. The studies on pulmonary hypertension patients undergoing anesthesia are limited. Most of them are retrospective, and the vast majority does not have a control group. And let's see a patient that came to a non-expert center, a 67-year-old male who presented for a left upper lobectomy with nothing significant in his history other than his smoking habit. The patient was fully functional in his daily life, and his preoperative vital signs were within normal limit. But the patient carries a cardiac ultrasound demonstrating an ASD as large as 25 millimeters, with dilated both his right chambers of the heart and pulmonary artery systolic pressure as high as 45. His ejection fraction is preserved, but he also holds a CT for his tumor assessment that measures the diameter of his pulmonary artery to 3.5 centimeters. So, two things are on the table. Do we proceed with the surgery or postpone for optimization? Several ideas came up, but almost none of them would, but they all either increase the risk or delay the surgery that much that maybe the tumor would be inoperable by the time he would fit for the thoracic surgery. So the patient that handled the case was not an expert, but he was a cardiac anesthesiologist who was familiar with pulmonary hypertension, and a pulmonary artery catheter is placed in the patient with the intention to be maintained during the OR for monitoring. Indeed, his pulmonary artery pressure is 48/30, his wedge pressure is 14, and he has increased PVR. So the patient is started on inhalation iloprost 24 hours prior to surgery, and there are instructions given about euvolemia, supplemented oxygen as needed, and prescribed medication to control his anxiety, and proceed to surgery.